Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Société Francophone de Nephrologie, Dialyse, Transplantation, die Österreichische Gesellschaft für Nephrologie, and the Junge Deutsche Gesellschaft für Nephrologie, Markus at Home welcomes Professor Markus Schlaich in Perth, Western Australia, and Professor Patrick Rossignol in Monaco to discuss the impact of endothelin receptor antagonists in patients with resistant hypertension, focusing upon their precision study. Dear Patrick, very happy to have you back at home. Dear Markus, welcome at home for the first time. You're actually the first guest from Western Australia after we had several experts from New South Wales and from Victoria. Thanks for joining us.
Pleasure.
Professor Markus Schlaich is nephrologist, hypertension specialist, and chair of the Dobney Hypertension Centre, which is a collaborative venture between the University of Western Australia and Royal Perth Hospital. Additionally, he is president of the Hypertension Australia and president-elect of the World Hypertension League. Professor Patrick Rossignol is nephrologist, vascular medicine specialist, and expert in hypertension. He is head of the Medical Specialties Service, Nephrology Haemodialysis at Princess Grace Hospital, and medical director of the Monaco private Haemodialysis Centre.
Thank you so much for having me. Wonderful to be the first presenter from Western Australia, which is the biggest state in Australia, but far on the west side, as the name indicates. So a great pleasure to be here. And together with Patrick Rossignol, who will speak after myself, we have the pleasure to talk about a very exciting development, endothelin receptor antagonists, and we'll focus on hypertension and chronic kidney disease. We've been part of a number of trials and studies in that context, and hopefully this will be informative, and we will have ambient time to discuss any questions you may have. These are my disclosures. And what we're going to talk about is predominantly two papers, two studies. One was the original publication of the so-called precision trial, which I will talk a bit more in detail, published in the Lancet in 2022, simultaneously presented as a late breaker at the American Heart Association meeting, and a spin-off from that paper where we focused on ambulatory blood pressure monitoring. For those who are in the blood pressure world, you know, ambulatory blood pressure monitoring is considered the gold standard. Most accurate, has lots of information in it, and I think there's some interesting data I would like to share. Just to start off and kick it off, while the endothelin system has been known of being of high importance for a long time, since its initial discovery in 1988, not many know that it is actually, from a physiological perspective, the most potent vasoconstrictor. And to make it simple, how does endothelin, or endothelin-1 in particular, works? It's produced predominantly by endothelial cells in response to a number of stressors, and it can bind to two different receptors, the ETA and the ETB receptor. ETA receptors are predominantly expressed on the vascular smooth muscle cells, and upon binding of ET1, it results in significant vasoconstriction. ETB receptors predominantly expressed on the endothelial cells, but also on the vascular smooth muscle cells, and activation of those tends to be a bit of a yin and yang and can cause vasodilation, but in certain pathophysiological contexts it can also contribute to vasoconstriction. So it's a bit complex, but there's also approaches in terms of selective ETA receptor antagonism as opposed to dual combination of ETA-ETB receptor antagonism, and we'll touch on that a bit later. Aside from vasoconstriction, it is important to note that endothelin exerts a number of relevant other consequences, such as vascular growth, inflammation, fibrosis, and that will be relevant when we talk about organ protection. The other important thing to note about endothelin is that it's widely expressed, not only in the vasculature and in the kidneys, which we probably focus on mostly today, but in the heart, in the brain, in virtually most organs, and the lungs are also very densely innervated with ET receptors. And as you would know, in many countries, some endothelin receptors have been approved for the treatment of pulmonary hypertension. But until the precision trial, it was not yet approved for systemic or arterial hypertension, and that's what we're going to talk about here. So let me just give you a very quick intro into the study design of Precision. So this was a trial exclusively in patients with resistant hypertension. The idea was that if somebody is resistant, truly takes their medication, obviously an adherence has been measured in this study, there's two possibilities. Either a very important pathway is not opposed, hence the use of an endothelin antagonist, or patients may not take their medication, or again, yet another undiscovered mechanism may be in place. So this study offered the opportunity to test whether endothelin antagonism may be very useful. And the design is, I think, worth to spend a few seconds on. So as usual, there's a screening, and people were put on standardized background therapy, a triple single pill combination to improve adherence. They then had a 4-week placebo run-in, and a substantial number of people fell out during that time, indicating that accurate blood pressure measurement, adequate adherence with prescribed medication, and ideally single pill combination tend to work very well. But those who remained uncontrolled were then here at week 0 randomized to either placebo or 2 doses of Aprocitentan, and a dual ETA-ETB receptor antagonist, 12.5, the lower dose, or 25. And the primary endpoint was assessed at 4 weeks, and that was office systolic blood pressure taken according to automated office blood pressure principles, to then identify whether or not continued Aprocitentan, in this instance in the higher dose, would maintain blood pressure control. All patients went into a single blind part of the study from week 4 to 36, while remaining on continued standard background therapy. And then at week 36, there was a re-randomization. Some remained on the dose of Aprocitentan, and others were put back on placebo. And this is how the slides now will be constructed to give us an indication what happened during those periods. This is the population and the baseline characteristics. They had to have a history of uncontrolled office blood pressure on at least 3 antihypertensives, and blood pressure had to be above 140. A number of exclusion criteria, in particular secondary causes, and major cardiovascular, renal, cerebrovascular events. NT-proBNP had to be below 500, and EGFR had to be above 15. And these are the characteristics distributed across those treatment groups. Average age around 62, slightly more male participant, predominantly white background. As we often see in these studies, clearly in the obese range, average body mass index was around 33, 34. A good number of people with significantly impaired kidney function, around a quarter of the population. We'll come back to that. Quite a few had evidence of albuminuria. Many were on 4 or more drugs, so really a heavily treated cohort. And then Aprocitentan on top, and you see the baseline blood pressure levels here. Half of the population had diabetes, and around 20% across the groups had heart failure. So really a very kind of morbid population. But this is, I think, practically very relevant, because this is the type of cohorts where we usually struggle to control blood pressure. And just to highlight again that these populations tend to be characterized by increased endothelin activation anyway, hence those specific criteria. This is the primary endpoint, and as you've seen in the initial study design, here is part 1, the double blind. In gray you see placebo, in the light blue 12.5, in the dark blue 25 milligrams. First observation is placebo works. Placebo always works, and it had a substantial blood pressure reduction, around 11, 12 millimeters of mercury. But the reduction with Aprocitentan at both doses was significantly more pronounced. We can discuss the placebo side of things, but in absolute terms, 15.3 millimeters of mercury. And keep in mind, these patients are already on the best drugs we have to throw at them, yet with the addition of this specific drug, a very nice blood pressure reduction, which was maintained during the single blind. And as you expect, once these patients were taken off after the re-randomization, blood pressure with those on placebo went up, and it was nicely maintained in those who stayed on the higher dose of aprocitentan. So, very clear-cut, clinically meaningful and statistically significant data. If we look at subgroup analysis, which I think is important to look at, and I'm not going to go through in detail, but you see here a distribution of age and UACR and EGFR. And what is perhaps notable that those with reduced EGFR, the elderly and those with more pronounced albuminuria, which tend to be the ones that are clinically very difficult to control, responded very well to this drug. And I think that is something we may want to discuss. Patrick will talk about the albuminuria aspect, so I'll skip over this. Very important, of course, is adverse events and specific events of special interest. And in the context of endothelin antagonist, as most of you would be familiar, the fluid retention component is an issue, and that was closely looked at. You see with a lower dose, the occurrence of edema/fluid retention was 9.1% of patients, essentially double that in the higher dose. So the side effects, as often is the case, was dose dependent. Still, some here in the placebo cohort. If you then looked at the longer term phase, it was very similar because all of them were on 25 milligrams. And key is that only led to discontinuation in a single patient. So this is manageable, but it is something we'll have to keep an eye on. And in the discussion, we can perhaps discuss how to manage this, but it responds usually very well to loop diuretics if needed, and there's other insights, but that's really the most important aspect from that perspective. 1 minute on ambulatory blood pressure data, which was also captured in this trial. Why ambulatory? It is the best predictor of outcomes, in particular nighttime blood pressure. This has been demonstrated now in a number of large studies, and ambulatory was also looked at in the Precision trial. In fact, more than 200 people in each of the treatment arms were on received ambulatory blood pressure monitoring. You see very similar baseline characteristics, but this is critical, I think. Here you see very nicely a beautiful separation of the curves, and this is the diurnal pattern of 24-hour blood pressure in blue placebo, yellow the lower dose, red the higher dose, and you see clearly across the 24-hour period, nice separation, more pronounced blood pressure reduction. And I would like to put your attention to the nighttime blood pressure, and that reduction was quite remarkable, actually more pronounced. And as you would know, patients with resistant hypertension tend to be characterized by non-dipping patterns, and that is potentially a very important finding, and that needs to be confirmed further. For the sake of time, I just skipped this one, but wanted to talk about blood pressure load as another measure we can take from ambulatory, which again was dramatically reduced, meaning that people are in the therapeutic range for much longer. And again, if we look at treatment emergent adverse events of special interest, it is the fluid retention. The numbers are very similar. But again, that's something we can touch on in the discussion. Perhaps of note, initial trials with endothelin antagonists had a bit of a safety concern regarding hepatotoxicity, which again, with the modern ones, does not seem to be an issue whatsoever. And that has been looked at specifically, but it seems to be very safe. So I'll conclude from those data. Aprocitentan, the dual endothelin antagonist, lowered both automated office and 24-hour blood pressure monitoring, particularly nighttime, which is perhaps an important finding. The effect was maintained over prolonged periods of time. Edema fluid retention is the most common AE. Importantly, this usually occurs in the first 4 weeks of initiating of treatment. That's the phase where we should monitor these patients, relatively easily to be counteracted by relevant diuretic therapy. And we believe that it's a very valuable alternative in terms of pharmacological management, particularly of resistant hypertension, but obviously also of hypertension in general. So I'll stop there and give Patrick, the opportunity to discuss very exciting data in the context of chronic kidney disease.
So I'm pleased to hand over and present the results from the CKD subgroups from Precision. My disclosures, importantly, owing to the exclusion criteria in Precision, a significant number of patients with resistant hypertension and chronic kidney disease have been enrolled. This enables us to dig onto this and assess aprocitentan efficacy and safety in 3 relevant subgroups: KDIGO high risk and very high risk patients, first, second, CKD 3 and 4 patients, and lastly, microalbuminuria versus macroalbuminuria patients. And just to present this graphically, taking advantage of the KDIGO heat map, you will see on the bottom the classical CKD 3-4 patients, the 2 columns with micro or macroalbuminuria, on using the heat map, the high risk or very high risk KDIGO patients. First, the KDIGO high risk and very high risk patient features at baseline. This again reflects real world complex and hard to treat population. Many patients being obese with history of heart failure and diabetes. And this is the patient features regarding UACR screening, a number of patients presenting with very high albuminuria, and a relevant proportion of the patients presenting with CKD 3B and 4. And these are the kinetics patterns over the trial, different phases, and consistent with what Markus presented. There was a significant relevant systolic blood pressure reduction. As you see here, this appears to be even more pronounced in these subgroups compared to the overall population, with a placebo-corrected delta of 9.7 mercury millimeters, which during the first double-blind phase, which persisted during the open-label phase, and again during the placebo withdrawal phase, the rebound in blood pressure in those patients assigned to placebo. This was again confirmed by ABPM data, both daytime and nighttime, and with again a rebound in those patients assigned to placebo during the placebo withdrawal phase. And importantly, there was a huge and clinically relevant and sustained UACR reduction observed in this very high and high KDIGO risk subgroup, 47% already at week 4, up to 60% with the patients with a higher doses, which persisted over time. And the safety profile was consistent with the overall trial population, with still some signs of congestion, but with a slightly decrease in hemoglobin and slight increase in body weight, but no change in NT-proBNP, actually, while 7 hospitalizations for heart failure events were observed, none of them with a lower dose. And there were no changes observed in relevant renal variables such as eGFR or sodium or potassium, which may warrant further discussion compared to other drugs which may be used in resistant hypertension. And again, back to the safety patterns, just to remind you that no discontinuation on 12.5 milligrams up to week 4 on only 3 patients, 2.1% of the study population, discontinued during the course of the trial. Now the CKD 3 and 4 patients, again, this does reflect real-world complex and hard-to-treat population, many patients being older than 65, many patients being obese, and these were undoubtedly patients with many comorbidities, heart failure, 21%, diabetes type 2, 75%. And again, clinically relevant systolic blood pressure reduction during the first phase. The placebo-corrected delta was 7.4 mercury millimeters in this subpopulation, which persisted over time and with a rebound after in the placebo withdrawal phase. This was again confirmed with ABPM, both daytime and nighttime. And again, there was a clinically relevant and sustained UACR reduction, which actually already impressive after 4 weeks, and this persisted over time. Meanwhile, the eGFR was maintained stable over the 48 weeks. Again, there was an excellent safety profile with no change in NT-proBNP, again, in this very sick population with CKD 3-4. Now, the last but not least group, comparing micro and macroalbuminuria, the patient features. Again, sick patients, most of them being obese ones. In these slides present us splitted the two populations, microalbuminuria in the left-hand side panel, placebo-corrected delta of 3.3 mercury millimeters during the first phase, maintained over time with a rebound during the placebo withdrawal phase, on an even more sustained, even more impressive blood pressure reduction in the macroalbuminuria subgroup, placebo-corrected delta of 11.7 mercury millimeters, which persisted over time with, again, the rebound during the placebo withdrawal phase. And there were, again, relevant reductions in UACR observed in actually both groups, both micro and macroalbuminuria. And interestingly, for the pathophysiological perspective, which was already tackled by Markus, if we get back to the KDIGO high-risk group on the left-hand side panel, on the CKD 3-4 subgroups on the right-hand side figures, we assess the potential correlation between blood pressure reduction and UACR reduction. And actually, the correlation was poor, which does strongly suggest that the reduction in blood pressure achieved with aprocitentan does not fully explain the observed reduction in UACR, since it was poor, since these two phenomena were poorly correlated. Therefore, additional mechanisms were likely involved in these renal protective effects, such as decreasing glomerular permeability, postglomerular vasodilation, or functional tubular changes. My last slide summarizes the findings of the main trial, as presented already by Markus. The blood pressure reduction after already 4 weeks, the placebo control phase in the subgroups, and the same features for the subgroups, high-risk subgroups, CKD 3-4 on macro versus microalbuminuria. And as you see here, there is at least a trend toward greater efficacy in these sicker populations with high risk or very high risk KDIGO, CKD, more advanced CKD, or more pronounced albuminuria. And my last thoughts relate to a paper we published already 10 years ago with several co-authors, including Gunnar, tackling the double challenge of resistant hypertension and chronic kidney disease. On my conclusion here, as with aprocitentan, we achieve relevant results in this very sick population with resistant hypertension and chronic kidney disease, especially more advanced kidney disease. Thank you.
Thank you very much, Patrick, and thank you, Markus, for sharing these important data and, of course, for leading this great project. I think the times are quite exciting in hypertension after a few dull years when we did not have many pharmacological innovations. Now we have data with aldosterone synthase inhibitors. We have data with preliminary data, I would say, with the RNA interference with zilebesiran. And here you come with a treatment targeting an old well-known pathophysiological mechanism, which was not really addressed in hypertension, with a new molecule, quite new molecule in the pharmacological armamentarium of endothelin antagonists. And I think this, of course, is very important for us working in the field of hypertension, and especially, as you've shown, Patrick, in the field of nephrology. Now, of course, I have a few questions and remarks. The first is, it's very difficult to do a trial in essential resistant hypertension. And finding these patients which are truly resistant and do not have secondary hypertension is quite a challenge. So you must be commended in this. And so how did you make sure there was no secondary hypertension? Was there a standardized protocol? Because especially if we look back at the pathway 2 results where spironolactone was tested, we saw that patients with low renin in this subpopulation had a better response to spironolactone, suggesting there was a part of primary aldo in the patients included, or which is not, of course, on-off disease. But how was this managed in your study? Were there specific examinations to rule out secondary hypertension? Are you fully sure they were all essential or not?
Well, I can perhaps respond to that. So the workup in terms of secondary causes were an exclusion criterion, but it was not necessarily mandated, to do every single test on earth available to ultimately exclude it. What the vast majority had is obviously a biochemical profile, particularly in the context of aldosteronism, so an aldosterone-renin ratio. Although we know, of course, often these patients are heavily medicated, and that can interfere with the aldosterone-renin ratios. They used to have renal artery imaging prior to exclude the most common forms. Obstructive sleep apnea was not an exclusion. So these are the factors. But similar to pathway 2, I think we cannot rule out 100% that there may not have been a few patients who had some form of secondary cause. And as we know, primary aldo is not necessarily a black and white. It's a bit of a spectrum on the aldosterone dysregulation curve. But so these patients were usually very well phenotyped, and the fact that they were usually on 4 or 5 antihypers, not just 3, indicates that they have been exposed very frequently also to spironolactone, for example, and so they have been very well worked up. But I would not put my hand in the fire to say there's absolutely no one who may have had some form of a secondary cause. But overall, I think it's been well excluded along those lines, which we use kind of clinically.
Yeah, that's actually the practical thing. So thank you. And regarding the initial phase of the study, looking at the important placebo effect, so you decided to use a triple combination, I suppose, to make sure all the patients had a standardized medication. Was the adherence tested or not? I mean, how can we be sure that some patients did really not take? All patients took this triple combination.
Yeah, again, adherence was tested and tested for the background medication, which was a single triple pill combination, and the numbers were on 98% in the study in terms of adherence with background medication. Endothelin antagonist, or the study medication, was not tested for, but the important aspect was to ensure that they actually take their medication and don't necessarily stop and then go back, which then can cause, of course, changes in blood pressure. And that was really learnings from a lot of other studies where these questions were asked. So that was an important component of it. But persistence and adherence with prescribed medication in terms of the background medication has been pretty high. And we really wanted to make sure they are on a single pill combination, where it's very clear data to indicate that adherence is significantly better than if you had 3 individual drugs. And again, they were on more than 3, the vast majority anyway.
Yeah, and one of the avenues now is to say that resistant hypertension has to be to put the diagnosis has to be on a single pill.
Spiral.
Yeah. So this isn't then afterwards, of course, on Spiro if it's the case. Regarding the subpopulation analysis, so thank you for these important data on CKD. I was wondering to to explain how the blood pressure effect is more important in CKD. Are we sure the pharmacokinetics are not impacted by reduced GFR? I mean, is aprocitentan more effective when GFR decreases for pharmacokinetic issues, or has this been ruled out?
So I have to admit that I'm not sure we have this pharmacokinetic data available. At least I have no. There is no evidence, to the best of my knowledge, that kidney function impairment may alter pharmacokinetics. I may hypothesize that those patients are presenting with more severe hypertension and are more likely to exhibit a blood pressure decrease, acknowledging the fact that all these patients were presenting with resistant hypertension. Most likely, these patients with more advanced CKD were more likely to exhibit higher blood pressure at baseline, and this translated on higher decline.
Okay, maybe more endothelial dysfunction. I don't know how.
Perhaps, but difficult to get this ascertained without biomarkers. I'm not sure that there is still some window of opportunity of assessing and comparing endothelial dysfunction biomarkers in this population. Perhaps, Markus, you know more from this.
Yeah, so there hasn't been any specific kind of tests such as flow-mediated dilation or anything relating specifically. There's some biomarkers that have been done, but not necessarily in that context. It was just too much for that study. But that would have been interesting, of course, to have some additional biomarkers in that context. But to my knowledge, they are not or have not been collected.
Okay, thank you. And last question, and then I'll hand over to my colleagues. Finally, how do you envision the position of this class, or I mean, aprocitentan per se, in the spectrum of treatments of hypertension? We have the three major classes with large MACE and mortality and security data, and thereafter comes the spironolactone or the beta blockers, depending on the context and the recommendations, the guidelines. And now we're going to have the aldosterone synthase inhibitors. Where does aprocitentan come with the clear but I mean not major reduction in blood pressure, a certain specific security profile, and I would say more important effect in CKD patients? How do you think guidelines are going to take this into account?
Please, Markus.
Yeah, thank you. I think that there's two different perspectives. One is from a clinical perspective, and then from a guideline perspective, perhaps. I mean, we don't have many data aside from the precision trial and the sub-studies, essentially, from that. But the way I see that, exactly along the lines you mentioned, I think worldwide we agree there's three major drug classes which we use ideally as a single pill combination, and the established fourth line therapy is currently a mineralocorticoid receptor antagonist, spironolactone. The problem with that is, of course, in people with a tendency towards hyperkalemia, particularly those with impaired kidney function. And if you look at the European guidelines, they actually separate the algorithm depending on your renal function above and below 30 mils. And obviously they say, don't use spironolactone if your eGFR is less than 30 because of the well appreciated risks. And that is perhaps where I see, with the current evidence, and that doesn't mean we couldn't potentially use them earlier, even earlier in the piece. But your point was very well taken. Why are those three drug classes the preferred first line? Because we have not only blood pressure lowering efficacy, but we have endpoint studies with those. So very hard to remove those. But I think aldosterone synthase inhibitors, potentially may replace spironolactone. They still have the issue with hyperkalemia, reduction in eGFR to some extent. And Patrick showed very nicely, endothelin antagonists do nothing in regards to potassium, sodium, eGFR. In fact, that may be on the one hand an excellent combination partner, perhaps with other drugs if you need more. But with Patrick's data in particular, I think I see that really as a great opportunity in patients with renal impairment and albuminuria, where we usually struggle. It seems to be very safe in that context. And I think this is where I clinically would think about this drug class as the most prominent kind of use in my clinical practice.
Very interesting. Thanks again to both of you.
So I have two more questions. So as we see in your study slides, the study included patients with NT-proBNP level less than 500. Above 500, they are excluded. And in advanced chronic kidney disease, we see many patients with values above 500 or patients with heart failure, usually a lot of above 500. So was it difficult to recruit these patients? And do you think maybe in future it will be also an option for patients with a higher NT-proBNP level?
Patrick, did you want to? Yeah.
Yes, if I may chime in, I would say that undiagnosed heart failure is an issue in many instances, especially for those patients with FPEF, arterial unprotected ejection fraction. And certainly, we should pay attention to NT-proBNP levels prior to initiating aprocitentan. Acknowledging the fact, especially those patients, that those patients with advanced CKD are more prone to heart failure, even undiagnosed. So I may recommend to assess NT-proBNP to rule out any undiagnosed or overlooked congestion.
If I could add to this, perhaps, and that was an important finding, people were switched to single pill combinations, including hydrochlorothiazide as a diuretic. And there were a good number of people who were actually previously already on loop diuretics, and they were withheld because that was replaced with hydrochlorothiazide. And that potentially is an issue, and we, in post-hoc analysis, we looked at that, and if people were to be left on more appropriate diuretic therapy, you may have actually seen less of the fluid retention. So I think the message, and that goes in line with the BNP, NT-proBNP data, ideally, before we put somebody on these drugs, we want them to be euvolemic as much as we can assess clinically and with those markers. So my recommendation, that was my learning from the trial as well, make sure these patients are well treated with diuretic therapy, whatever is required. If you're confident they're now euvolemic by whatever means you want to do that, then I think it is very safe to add endothelin antagonists on top of it. You still monitor it for 4 or 6 weeks initially, but then I think it's relatively smooth sailing.
And one last question from my side. You show we observe a great reduction in the urine albumin creatinine ratio, but we don't see a relevant reduction in eGFR like we see in SGLT2 inhibitors. And because I think we thought that maybe make a hemodynamic effect with this sort of medication, but why? What's the mechanism that we don't see the reduction in eGFR? And maybe this treatment is sometimes for people outside of resistant hypertension with proteinuria maybe expected in future?
It's purely hypothetical, but what about considering an eGFR reduction, which was neutralized by an improvement in eGFR? In other words, the hemodynamic drop in blood pressure, which we may expect in patients with lower blood pressure, perhaps was neutralized, was an improvement in eGFR with this vasodilation. So perhaps, but at the end of the day, the results were neutral with regard to eGFR over time, which is really reassuring and exciting for the future, because acknowledging the fact that a huge UACR reduction was observed, this reduction was at least not triggered by the eGFR reduction.
two final questions from my part. So the first one would be, how sure are we that the drop in hemoglobin levels is purely caused by hemodilation and not by some effects on the bone marrow? The second would be the obvious question. Even though we have this fantastic data, the drug is not yet available in the EU, and I guess also not in Monaco, which is not part of the EU, and there are strategic reasons behind that. But are there other companies developing other endothelin receptor antagonists which may also enter the market in the, say, foreseeable future?
Excellent question. So in terms of the hemodilution, the slight reduction in hemoglobin hematocrit, plasma volume assessments were taken, and it very clearly seems a hemodilution effect, and there was no evidence, at least with the differential blood results, that there was any kind of suppression of bone marrow activity. Companies, as far as I know, they're not developing it necessarily in the context of hypertension, which aprocitentan was done. But as you know, there's a number of components or drugs, particularly for renal protection, zibotentan, for example, combined with SGLT2 inhibition. There's trials ongoing, and that's a very attractive aspect, particularly in the nephrology world with IgA nephropathy and others, where we have those smaller drugs, ETA receptors in particular, that have been tested and been shown to be quite effective.
Thank you for joining us here in our webinar by Markus at Home the first time. And again, it was a pleasure to meet you here. And I'm sure that we will hopefully meet again in future, because I think there's a lot to talk about, and a lot of studies will and studied results will come in the next month and years. And maybe Professor Rossignol, maybe we can talk about the retreat frail trial in the future, something we would really like to talk about. And thank you very much for joining us.
You're very welcome. Thank you for the invite.
Great pleasure. Thank you so much. If you think about anything in renal innovation and CKD, let me know. That's another topic which would be potentially of interest.